Hi, everyone. My name's Solomay Tibabu. I'm the host of Going Digital Behavioral Health Tech. We've got a great conversation today with Zack from Ophelia. Thanks for being with us. And before we get started, I would love if you could offer a brief introduction on yourself and then Ophelia Health as well.
Sure. Thank you for having me, Salome. My name is Zack. I am co-founder and CEO of Ophelia, which is a virtual addiction treatment provider focused on expanding high-quality access to evidence-based care for patients with opioid use disorder. I started working on Ophelia a couple years ago after losing a girl that I loved to an overdose, someone who had every reason to get access to quality care. Neither of us, frankly, had ever heard the term medication-assisted treatment, and she was highly stigmatized by the treatment industry, knew that she needed the help of medication if she were to stop using, but found it easier to get on the black market. Sadly, that medication became harder and harder to come by. She was forced to use intermittently, and one day she overdosed and died. And so the entire mission of Ophelia is to take evidence-based treatment and redesign it in a way that works for people, focused on the 80% of Americans with opioid use disorder who are unable to access treatment at all, many of whom are resorting to the black market just like she did.
Thanks so much for sharing. I'm sorry to hear that. And unfortunately, we hear stories like this every day. So I really thank you for the work that you do. For those who aren't familiar, can you talk a little bit more about what it is that Ophelia does and some of your services?
Sure. Well, a little bit of context first might be useful on the opioid epidemic. It turns out that we have treatments that work extremely well for opioid use disorder. They're well researched, and they look a lot like the treatment you might get for depression or anxiety. So it's medication plus support and therapy long-term, highly effective at keeping people alive, also saves the healthcare system lots of money, is already covered by insurance, and looks a lot like what most people struggling are seeking, but almost the opposite of what we traditionally think of as rehab. And unfortunately, 4 out of 5 Americans who need treatment are not getting it. And a large percentage of them are resorting to the black market to buy the exact same medication because it's too difficult to get from legitimate clinical sources. So Ophelia exists to make this treatment more accessible. And that means providing evidence-based synchronous telehealth and wraparound services for patients all over the country, with a special interest in making treatment easier to opt into and easier to stick with for those who have privacy concerns, jobs, families, geographic barriers in the way of seeking and adhering to treatment in the first place.
That's pretty astounding. If we could talk a little bit more about that, I feel like we're hearing so much about opioids in the news. Can you talk more about just the challenges that are going on with the opioid epidemic?
Yeah. Sadly, much of the problem stems from constraints that have been put in place by the government and ineffective reimbursement policy in the hands of payers. So the first thing to note is that in order to prescribe the medication that we prescribe, chemical is buprenorphine, you might know it branded as Suboxone, it's not enough to have a prescription pad and that automatically gives you the authority to write prescriptions for any controlled substance, be it OxyContin, Vicodin, Adderall, Xanax. In order to prescribe Suboxone, you need a separate license from the DEA, the federal government. And only about 5% of clinicians in this country have that license. And then once you have your license, you're capped at the number of patients you can treat simultaneously, which for most clinicians is only about 30. So if you can only treat 30 patients, well, you're not really eligible for a full-time hired and addiction treatment program. And unsurprisingly, many go to work in other places and don't end up using their license at all. And so there is a supply shortage of trained, licensed clinicians. On top of that, you add legacy in-person visit requirements, which have historically forced programs to set up brick and mortars wherever they want to serve patients, rely on W-2 expensive clinicians because they're in short supply, and the way they get paid is through fee-for-service reimbursement by the insurance companies, in which they basically make money every time a patient does something, every time you come into the clinic, sit in a group, pee in a cup, and without serving patients excessively, it's very hard for them to stay in business. And so that's created an environment in which if you want to use your insurance, you'll be forced to do things that are not medically necessary and threaten your personal and professional obligations as well as your concern for privacy. Or you can call up the same person who sells you drugs and buy this medication. And while it may cost you $1,000 or more per month for a significant number of people, that sadly is preferable. We think about ourselves as using telemedicine and patient-centered design to remove barriers that have historically kept back programs from optimizing for things like clinical efficacy and patient satisfaction. And in order to enable access at a broad scale, contracting with all forms of payer from Medicaid to commercial to Medicare and even cash pay, because for many of these patients, they're spending lots and lots of money. And a cash pay model, despite being a high price point, is still representative of cost savings.
Thanks so much for explaining that. And I heard you say Bupe earlier. Can you talk about some of the medications that you're delivering? Would you fair to say these MAT treatments are best class right now?
Yeah. So medication-assisted treatment is widely recognized as the gold standard of care. There are at least 3 FDA-approved medications, including buprenorphine, methadone, naltrexone, and also naloxone, which is the overdose reversal drug, often branded Narcan. Buprenorphine is the main medication that we prescribe, and on top of that, we'll add a series of non-controlled substances that help with withdrawal symptoms, sleep, anxiety, restless leg, as well as medications for co-occurring depression and anxiety within our patient population.
Great, thanks. And on this theme of access, how do individuals access your services? Like, what is your clinical delivery method?
Yeah, I think this is what makes Ophelia most unique. Often we talk about telehealth as simply an alternate delivery mechanism for traditional care. And the questions that are asked are around the quality of care versus in-person treatment. But what is underappreciated is that a telehealth program has the ability to expand access by targeting people who may not have entered treatment through traditional delivery channels. So most programs in addiction treatment and healthcare broadly rely on referrals from the healthcare system to recruit patients. And in the world of addiction treatment, often that referral comes from the emergency department or the correctional system or an inpatient detox program. But we know that if you're waiting for a referral from one of those places, well, then you're only serving a sliver of the population because 4 out of 5 patients are undiagnosed. And even worse, you're serving them after an escalation event has already occurred that has landed them in the ED or in a detox program. And meanwhile, businesses across other areas of the economy have figured out how to target and engage people through the use of platforms, among them 2 of the most valuable companies in the world, Facebook and Google, which are essentially built on algorithms that let you target, identify, and engage patients. So we are, predominantly D2C or direct to patient, as I like to call it. And the vast majority of patients who seek treatment with Ophelia are recruited directly through online channels, opting into care before they wind up in the ED and their condition, meaningfully escalates.
I really like this idea of connecting with individuals before it has to escalate to that level. But then connecting with them online, what can you say about safeguarding against any privacy concerns?
Well, I think that telemedicine is ideal for anyone sensitive to privacy issues because, while one of our missions certainly is to reduce the stigma around drug use and treatment broadly, that's a hard problem for a startup to tackle and requires time and buy-in from many, many stakeholders. But what we can do is we can make stigma less of a barrier by giving people the option of privacy so that they don't have to face the stigma if they don't want to. And, with telemedicine, you can get treated without anybody else knowing. You can do your visits in the privacy of your home. You can do them on your lunch break. You don't have to take time off of work to go to a program. You can choose to involve your friends and family if you want to, but you're not required to. And in a world in which privacy is one of the biggest reasons for people not seeking care, telemedicine is sort of a godsend that allows privacy concerns to become, largely irrelevant because you get to choose privacy if you want it.
Absolutely. Thank you. Unfortunately, we've all heard the stories of patients going in person and struggling with substance use issues and are being discriminated against. And we obviously need to change a lot still without stating the obvious there, but that makes a lot of sense. Now, in terms of the impact that Ophelia has been having on patients, can you talk a little bit about that? Any data you're seeing?
Yeah. When I first conceived of Ophelia, my thought process was simply medication-assisted treatment is highly effective. The problem is access. So if we can just get this treatment in the hands of more patients and be as good or even almost as good as traditional modalities, well, then we'd be doing important work. What I didn't appreciate at the time is that telemedicine can also improve the efficacy of treatment itself. And so the data is clear that we are expanding access to patients who would not have otherwise been able to engage in treatment. And we know that 40% of counties in this country don't have a single X-waivered prescriber. Many of our patients are in those counties. Most of our patients are Medicaid enrollees who have not been able to access treatment before. The vast majority don't even engage with primary care. So we're their only touch point to the healthcare system. But then you look at the outcomes and, of course, the satisfaction that we're generating for our patients. And the number one outcome in addiction treatment is retention in care. The historical industry average retention at about 6 months is roughly 30% or 35%. We're seeing 6-month retention of 70%, 1-year retention of about 60%, and 2-year retention of about 50%. So there's a good reason to believe that we are expanding access to treatment, and at least as measured by retention, nearly doubling the efficacy of the treatment itself.
That's remarkable. Amazing. And I know you mentioned earlier working with all lines of business in terms of payers. Can you talk a little bit more about the partners you work with and what problems you're solving for them?
Yeah, we have to date built the organization to exist sort of in a silo, candidly, from the rest of the healthcare ecosystem, because the ecosystem itself has been underperforming and is the reason that these problems exist in the first place. So we are, contracted with many payers, but we're not getting a lot of help from them outside of payment. They're not referring us patients. We're not really sharing data with them. We're relying on them to finance the care for their members, but we're the ones that are out there recruiting the members, educating them, getting them into care, and making sure that they stay healthy for the long term. As we evolve, we would absolutely love to better integrate with the ecosystem more broadly, and that includes health systems, emergency departments, FQHCs, inpatient detox programs, the correctional system. But for now, we're sort of doing the hard work to recruit and get patients into care ourselves and relying on our payer partners to simply finance the cost of that care.
That's really helpful. And speaking of payers, Zack, I know you mentioned earlier that reimbursement policy was a barrier in terms of expanding access. Can you say a little bit more about that? Absolutely.
I believe that payers hold the key to solving this crisis. And the sad reality is that payment policy and payment reform won't simply lead to far fewer deaths. It's also smart business for them. And the fact that they're not doing it is, a problem for their shareholders who may not even know or care about the mission. So what do we know? We know that medication-assisted treatment saves lives and it also saves money. And there was a study done by United Healthcare and Optum Labs showing a 76% reduction in ED visits and a $10,000 cost savings in just the first 3 months of a patient who received MAT versus one who didn't. So there's good reason for payers to want to pay for treatment and pay for it appropriately, because more providers would do it, fewer people would die, and they would spend less money in the process, which means expand their bottom line and return more money to their shareholders. Yet they're simply not doing it. We know that Medicaid programs tend to pay incorrectly for this treatment because providers are bundled into the category of general primary care for the most part, where they are just allowed to bill for synchronous telehealth visits, and the rates are really low. And as a result, many providers do not even want to accept Medicaid. And what happens is patients who don't receive treatment because they need to find a Medicaid provider wind up in the emergency department, and the organizations responsible for covering their healthcare expenditures end up underwater. Now, the sad part, or the shocking part to me, is that many of the companies responsible for managing Medicaid and Medicare dollars are private. So we're talking about big publicly traded companies like United Healthcare and Aetna and Centene, which is to say that by not paying appropriately for this treatment, they are directly responsible to the surge in overdose deaths that we've seen just in the past year. They're also spending too much on addiction treatment, and any shareholder should be up in arms. Now, when you consider the fact that Medicare and Medicaid dollars are funded by taxpayers, this cost is being borne by the general public as well. Now, in 2020, CMS came out with a bundled code for a telehealth-based addiction treatment. Remarkably, this was before the pandemic even occurred, and so it's wonderful in retrospect that they were thinking about this problem. But 2 years later, payers have failed to adopt the code. They're still paying inadequately, which means fee-for-service only covering a fraction of services at a rate that does not incentivize most providers to provide treatment. So it's as if we have a cure for cancer, but the organizations responsible for funding it are not paying enough to get people to offer it, even though offering it would save them money in the form of avoided ED visits. And it's a true travesty for the entire industry.
What do you think is the cause of this holdup?
I think that it's in part due to bureaucracy and inertia within large healthcare organizations. So over the last handful of years, Medicaid has been carved out to private companies, managed care organizations, with the expectation that they would be more effective at managing risk than the state governments. They really haven't been. And it may simply be that they are, large organizations with many priorities, and the people in charge of making these decisions aren't incentivized to think creatively. But I actually think that there's more to it. And I think it comes down to, two factors. One is most patients with opioid use disorder in this country are invisible to the healthcare system. We know 4 out of 5 are not getting treatment, which means when payer executives look through their claims data, they're looking at diagnosis codes that correspond with their major cost drivers. And someone who winds up in the emergency department may not be categorized as having an opioid use disorder. And many of the people who will wind up in the emergency department this coming year are not yet known to them. And so their data sets are very limited, and they don't reflect the true cost burden they're bearing because most patients are not engaging with their systems at all. I think the second piece is that the people to drive adoption are the providers, who are responsible for negotiating these contracts. And up until recently, there weren't very many large-scale, well-funded medication-assisted treatment providers, and certainly not in the realm of telehealth. So I think what you're going to see over the coming years is providers who have some sort of negotiating leverage, educating payers, and walking them through the process about how you implement these codes effectively, how you do so to save the organizations that are responsible for footing the bills money, and how to better serve members, whether those members are visible to them or not. And we're in the very early stages of reimbursement reform within MAT, and I am proud to say that we hope to be on the leading edge of those conversations.
Thanks so much. There's so much opportunity for all stakeholders to do so much more. So I'm really glad that you highlighted these items. And speaking of doing so much more, looking forward for the next 12 months or so, where do you see Ophelia Health heading?
We're focused today on doing what we're doing in more states for more people without getting distracted with other things that we could be doing. I mean, we've seen really fast adoption by patients and clinicians, high satisfaction scores among both groups, superb clinical outcomes. Yet we're only operating live in 14 states, and there are many other states that need these services. So we want to make sure that we can scale, efficiently and responsibly. But there's a lot more work to do before we even begin to make a real dent in this problem. And the innovation for us will come in the form of, additional efficiency improvements within our program, smarter clinical protocols, better data management, and eventually additional services for patients who have opioid use disorder. Remember, almost 80% of our patients don't see a primary care doctor or didn't when they initiated treatment with us. Yet half of them are stable 2 years later. We've solved their primary health condition, but they have other disorders that need to be treated. And perhaps Ophelia can treat some of them, but certainly those that it can't treat internally, it can facilitate solutions for through partnerships with other providers, with primary care, with inpatient facilities. And that's the type of work that I look forward to working with our payer partners to help develop.
Awesome. Thank you so much. And Zack, I always have so many more questions, but we're running out of time. So if I could ask you one more thing, how can folks get involved or partner with you and learn more?
I think that the value creation framework that we have set up at Ophelia and other providers have set up within their organizations couldn't be stronger in terms of what really matters for patients and for the healthcare system at large. Now, to make that a little bit more concrete, a telehealth first model is superior to brick and mortar care for most patients who have OUD across all relevant dimensions. It leads to greater access, it's lower cost, it delivers superior outcomes in terms of retention, and it's vastly preferred by patients. If all of those things are true, then much of the industry should give way to digital first providers like Ophelia. And going a step further, the industry should expand to include the 80% of people who are not accessing it today because they're instead engaging with the black markets. The challenge is to turn value creation into value capture, and that requires smarter payment policy on the behalf of payers. Now, I mentioned organizational inertia as a challenge for payers, but there's lots that startups can do to make their transition to bundled payment or risk-based contracting more seamless and more turnkey, so that we don't have to go in and recreate the wheel each time we want to get a contract with a payer. So any startup out there that wants to use data and technology to help payers transition into the world of value-based care will be doing wonders for all of the providers out there that are focused on providing that care with high quality and low cost.
Excellent. Thanks so much for your time and sharing these great thoughts with us.
Thank you so much.